Welcome once again to the FRCS Mentor group Wednesday teaching session. As always, we're very pleased to have a Viva session at the end of this talk. But for the recorded part of this section today, I'm very pleased, I'm very honored to speak, to introduce Mr. Mahaluximvala from Prince Alexandria Hospital. By way of background, this is my mentor before the mentor group started. He's someone that taught me a lot, and I really loved going to his courses, and I have a lot of respect for his views on managing cases, as well as in other things, of course.
Should I share the screen, Shwan, now?
Please, if you don't mind.
Yep. Can you see it now? I'll go to slideshow. Yeah, can you see that now, Shwan?
Yes, it's projecting well.
Lovely. All right. So thank you very much, Shwan, for the introduction. And as you know, this group is really closest to my heart for teaching. So thanks again for inviting me. As we've always discussed, one of the issues for these type of topics like fracture healing is that these topics are what we don't really discuss in the coffee room every day. And hence, what comes out of our mouth, the way we verbalize, is important for these difficult topics. Shwan, is there any time frame for it, or
no,
25 minutes, or maybe less as well, and then we have time for questions if that's all right.
I'm very happy for you to go as long as you need to, because I know it's going to be very useful.
Okay. No, thanks. So coming back to this topic, the way I thought I'll do it is start with the plan, and we'll talk about types of fracture healing. Second, we talk about stages of fracture healing. Then let's talk about the key facts, for example, collagen, non-union, delayed union, etc. And then factors which influence healing. Now, in these type of what I call difficult topics for the basic science Viva, for the part one, it is knowledge-based. And that's not something which, when we give talks, I think we can give you the most, because that's really from MCQs, truly getting your knowledge. But for the part two, what I find in all the courses I've given or when I examine candidates, is that the verbalization of these concepts becomes a bit haywire. So therefore, I thought, let's concentrate, and this will be mainly for the part two type of preparation, okay? So that we can have some knowledge, but how do we put the knowledge together in a simplified form so that we can talk sense? Now, all the senior mentors who are on, do you agree that this is one of those topics where everybody has some knowledge, but when they put it together, it may not come out to give them a 7 or 8? What do you think, Sean and Fawad and Mustafa?
Yes, I agree. It's a very, because there are lots of things going on with this topic, and what the candidates find it difficult is to where to start and where to end.
Correct.
And that's why it's very important that they have the basic concepts right, and use the right buzzwords which can help them to score 7 and 8 rather than a 6.
Yeah. Good. So thanks for that. That's what my feeling was. So moving on, the first thing I want you to take away, which I think everybody confuses everyone on this topic, that quite a lot of people confuse the types of fracture healing with the stages, okay? And it's the only thing you take out of this talk when you prepare from any textbook you want to prepare from. And a lot of this from concise orthopedic notes of Firas Anout, which is got this topic covered, is that there is something called types of fracture healing, and second is the stages, and they are not interchangeable, they are separate. So let's start with the types of fracture healing. the way I'll tell the examiner, or what you should say, is yes, in types of fracture healing, it depends on what part of the bone or the structures contribute to the healing. So say the types of fracture healing could be from the cortex, from the periosteum, from the soft tissue, and the bone marrow. And then say the most prominent, or what we discuss most of the time, would be cortex and periosteum. Then moving on, we say the types of fracture healing are also divided into primary, where the contributing factor is the cortex, so say it in that manner, and secondary, where the contributing factor is the periosteum and the soft tissues. Because that's your big heading to start dividing how to talk on this. Then say, I do know that in secondary healing, when the periosteum contributes to this healing, the periosteum contributes to the healing in two manners. The first manner is a word called intramembranous ossification. Just remember, it doesn't matter, but don't confuse it. And the second is endochondral ossification. And then say the soft tissue, however, contributes by only endochondral ossification. So we are still on types of fracture healing. We've not gone to any stages. Then tell the examiner that in the cortex, which I'm talking about, which contributes to primary healing, it happens when there's rigid fixation, anatomical reduction, and I do know that there has to be a very low interfragmentary strain, and I do know that strain has to be less than 2%. So again, repeating it in a manner which should come out from your mouths, not mine, is when the cortex contributes to primary healing, the circumstances which allow it would be anatomical reduction, rigid fixation, a decrease in the interfragmentary strain to less than 2%. Then say the way this works will be with what is called as cutting cones. And then say I like to divide this method of cutting cones into three parts. The first word which you want to use is the osteoclasts. Remember now, we are using correct words. The osteoclasts will burrow. And this is the cutting zone, not the cone. The cone is divided into three parts. The first is the osteoclast burrowing to create a channel, which is called the cutting zone. Then behind that, new blood vessels and new Haversian systems form, and mesenchymal cells are brought there, and that's called your reversal zone. And then say, I do know that osteoclasts will migrate and form the bone, which is the closing zone. Right, so this is where we are for the types of fracture healing. And then say, in the periosteum healing, this happens when the strain is between 2 and 10%. It is inhibited by true rigid fixation and enhanced by motion. And this is when you have your other forms of healing like cast braces, etc. And I do know, like I said, if the periosteum is giving this type of healing, the secondary healing, in the intramembranous ossification part of the periosteum healing, I do know that uncommitted mesenchymal cells, so use this word and try to use the word uncommitted mesenchymal cells, further from the fracture site. So tell the examiner, I'm drawing the fracture, and further from the fracture site, they form bone directly. Now keep this point in mind, because if you want your, like Fuad said, if you want your 7 or 8, and later on in your viva or your first question of your viva, you're asked in delayed union, what happens? And then you give your definition of delayed union. And then they ask you, but tell me what happens at the cell level? Then you need to know this stage. So keep in mind, remember we said the periosteum is responsible for healing in two manners, intramembranous ossification and endochondral ossification. In the intramembranous ossification, uncommitted mesenchymal cells away from the fracture form bone directly. Then the periosteum is still contributing, And the second manner it contributes is the endochondral ossification. And in this one, you have your true bone healing, which is uncommitted mesenchymal cells closer to the fracture. And this is the standard classical method where there's calcification first and then it's replaced by bone. Okay, so this is your endochondral ossification. Then remember, this is something which is not always in textbook, but it's an easy way to remember. The soft tissues are also responsible for your healing. And the soft tissues responsible for healing are through endochondral ossification. And this is the uncommitted mesenchymal cells. And again, decreased by rigid immobilization. And again, not commonly known, but in textbooks, there'll be bone fractures, bone marrow. And in the bone marrow, it's an early response, and this is independent of immobilization. Now, you don't really need to know this, as no one's going to ask you, does the bone marrow contribute? But it's a nice way of knowing in your mind that all the parts of the bone contribute to healing, but the ones which we commonly talk about would be the cortex and the periosteum and the soft tissues. So moving on, fracture healing. Now, there are many textbooks will have different stages, will have different words. And I'm telling you again, just remember whatever your mind can remember to 4 or 5 stages. But I feel I've put together these because it truly encompasses a little more of your brain to remember, but it actually covers the true 5 stages. So remember, the first stage is inflammation and hematoma formation. So why don't you remember, a hematoma forms first, and then you get an inflammatory response. But that is all one stage, okay? The second, just remember angiogenesis and cartilage formation. That's your second stage. The third would be calcification of that cartilage. Fourth will be removal of the cartilage, and then bone formation and bone remodeling. So going back again, where I find people get confused, that they interchange the first 2, right? So it's try to remember that hematoma and inflammation is your first stage. Angiogenesis and true cartilage formation is your second. The calcification of that cartilage will be third. Removal of the cartilage will be fourth, and then finish with bone formation and bone remodeling. So let's do each one to know where we are. So in the stages of fracture healing, in the inflammation and hematoma, that's the initial. From bang, your fracture happens, you get a clot, you get fibrin, you get platelets are responsible, all the cells come in, there are macrophages there, the WCs come in, and that whole process where the cells are coming in takes from 0 to 1 week. Just remember this figure. And what is responsible for that? Platelets are very strongly responsible for this stage. And you have TGFB and the PDF. We'll come to that later. And remember, tell the examiner, I do know they are signaling molecules, and this enhances all the inflammatory response at this stage. Then go on to the second stage, which is the angiogenesis, which is the blood vessels coming in and cartilage formation. And then say, at this stage, I do know that, remember we said the callus is contributed from the periosteum and the soft tissues. And at 10 days, remember this date, at 10 days, it's ready for calcification. So very early on after the inflammatory hematoma, everything is ready and you're ready for the calcification to happen. Then you have to have something called cartilage calcification. So the cartilage which is there has to be calcified. And that happens, again, remember the figure, that's from 10 to 14 days. And the words we have to remember is the chondrocytes will undergo mitosis. Starting, remember, at the magic figure, we said 10 days and going on to 14 days with the vesicles. And tell the examiner, the phosphate ions precipitate with calcium. So that is your calcification. So once again, we are not scientists, we are not physicists, we are not molecular biologists, we are orthopedic surgeons. So we don't need to do any more than 1 or 2 sentences on these statements which I've made, but that's all you need to know. But you can't fluff around it. You need to say it like this. So again, it's a confusing part, the cartilage calcification. The way I'll say it is the chondrocytes are responsible for that. They undergo mitosis beginning at the 10-day mark, and the phosphate ions precipitate with the calcium. Then we have to go on to the cartilage removal. So the chondroclasts are responsible for this. They come in with the ingrowth blood vessels and they start removing the cartilage. So the chondroclasts come in now to remove the cartilage. And finally, we have the woven bone replacing this cartilage. And this is similar to your secondary spongiosa. And once we have bone formation, we move on to bone remodeling. And for that, again, say, I do know, according to Wolff's law, the maximum osteoblastic, which is bone forming activity, will happen on the compressive side, and the woven bone will ultimately form lamellar bone. Okay, so once again, 1 or 2 lines, but the correct terminology. So once we finish this, what have we done so far? So in about 15 minutes, we've covered the types and the stages. And now we'll go on to just individual slides talking about concepts you may be asked in the Viva or you need to know. So let's move on to the first one. You probably need to know the diamond concept of regeneration or healing. And for that, just remember the 4 words: osteoinduction, where growth factors are responsible for osteoinduction. There's osteoconduction, which is your scaffolding. And there's a scaffolding and you get osteoconduction. Osteogenesis is from your uncommitted mesenchymal stem cells, which are going to be your ultimate osteogenesis. And all this can only work if you have a mechanical environment which is conducive to bone healing. And the most important mechanical environment would be the vascular status. And hence, that's one. So you need to know about the diamond theory. Let's need to know about the second is about the collagen types. We go on reading this from Miller, we go on reading it from textbooks, and we never things in our mind. The way I remember it is in collagen types, we have type 2 and type 9, which are responsible for cartilage, which is a chondroid. Then we have 1 and 5, which are responsible for bone. And we have osteopectin, osteocalcin, etc. Right? So now we come on to growth factors. In growth factors, the most common one we need to know is the BMP. In that, we have the osteoinductive, which ultimately forms mesenchymal cells, and you get your osteoblasts. And in BMP, you have BMP2, you have 4, you have 5, you have 6, all of them osteogenic. Okay, so the most important is BMP. It's osteoinductive, ultimately will form osteoblasts. And tell the examiner, within BMP, which is bone morphogenetic protein, I know there are different types, which is 2, 4, 5, 6, 9. Okay, but that again, like I said, these things you probably will know because you prepared for your type 1. Then tell the examiner, I do know that growth factors are responsible for my first stage, which is osteoinductive. And besides BMP, I know there's something called TGF beta. And that is more responsible for your type 2 collagen. Okay, so more cartilage responsible. So that's your TGF beta. Then say there's a IGF-2, which again stimulates your bone forming. So if you ask in a nutshell, which are the growth factors which are true bone forming, will be BMP and IGF-2. And the one which is more for your collagen will be the TGF beta. Once again, there's no use arguing with your friends or colleagues that this is not, we are not scientists on molecular basis. This is probably there. Just remember these 3-4 statements or phrases, and that should be enough to impress the examiner. So now at this stage, I'll probably just ask my colleague, senior mentors, is that do you agree that most of the questions you all will be asking or are asked at the basic science level on fracture healing in some form or manner would cover these 3 points or 4 points which I've mentioned about?
Yes, absolutely. Knowing the types, but also the stages, and recognizing the difference between the two, and then what is involved in each of those stages. Yeah, that pretty much covers everything.
Covers everything. And then also you agree that that they will be asking about the diamond theory, they may ask, and you need to know some words about the growth factors, correct?
Yeah,
which we have to know. And this, therefore, I don't think there's much more which you can read from textbook to enhance your knowledge for the part 2. Because now all this, we want to try to see whether we can get your 7 or 8 if it comes to true questions about in real life or in clinical scenarios. So I'll move on to the next little part of this, which is what is delayed union and what is non-union. Now, this is again, whenever I ask a question, so I always say, look, it's 3 months down the line and I show an x-ray of a humerus treated conservatively, and I show the x-ray of the AP and lateral, and let's say it's not 3 months, it's 2 months down the line, and I ask the candidates, tell me, what do you think? They always say, yeah, it may be, I can see the fracture line visible. Then I always ask, is it a non-union or is it a delayed union? And most will say, oh, it's 8 weeks, I'll call it a delayed union. And then I say, okay, I'm giving you the same scenario, but it's 12 weeks. And they say the same thing. And then I say, a same scenario, I give it 14 weeks. So try not to be in a position where the examiner is just pushing the same thing without you coming down to the true question of what is needed for what is delayed union and non-union. So I believe that the best way of answering what is delayed union would be delayed union. The fracture has not failed to unite in the anticipated stage phase of that fracture. Okay, so different bones will have different times to healing. So the simplest definition of delayed union is a fracture has failed to unite as anticipated or has failed to unite in the time frame of that fracture. However, what I like to add is that in a delayed union, which is opposed to non-union, actually, we may not be seeing the fracture healing radiologically, but we all agree that some biological activity is happening. So therefore, if you want to really impress your examiner or you truly want to understand it, you can say, therefore, I do know at the cell level or at the real primary healing level or the secondary healing level, what happens is that the periosteum reaction for some reason is not doing its job as well. And we do know that in the periosteum reaction, remember we talked about it, there are 2 types, the intramembranous ossification, where bone is formed directly, and that part which we see earlier has probably not happened in delayed union. So those fractures, periosteal stripping, etc., we don't see the bone, and that is the true cell level of what is happening. But do we all agree that some biological activity is happening, and that could be activity happening from other parts of the bone contributing to healing? So the soft tissue is contributing, a bit of the periosteum is contributing in endochondral ossification. So all that is happening in the background, and that's why we say that healing will actually happen if the environment is good. And now let's oppose that to what is non-union. So I believe the correct best definition of non-union would be, I know the FDA definition is so many months and 3 months of no activity, but the better way of saying it, in my opinion, would be cessation at all attempts at union, both clinically and radiologically, and the fracture will not unite unless surgical intervention. So why I believe this definition encompasses what we actually do in clinical practice and what actually we tell the examiner is that I believe now, looking at this X-ray, that there's tapering of the bone ends, there's a large gap seen, radiologically, there's sclerosis of the bone end. So you agree this radiological scene which I'm seeing truly is that the fracture will not unite. And of course, clinically, the patient would have a mobility at the fracture site, he'll have pain. So once you as a surgeon have made a decision that no, it's not going to unite unless it's surgical intervention, that's your non-union. Obviously, couple it with the true definition of so many months down the line with 3 months of not healing. And therefore, if you ask at the cell level what is happening, at the cell level, there's actually true cessation of both the periosteal and all the other endosteal healing responses have all ceased. And therefore, it is non-union. So I hope I've made myself clear as to what truly is delayed union, non-union, and impressed the examiner by really now knowing the stage and the types you've gone down to say that. So let's, the next, my senior mentors, anything else on this point in brief, or do you agree this is another point where there's always, when we ask this, do you agree there's always, everybody's arguing with each other and trying to say this is a definition of, do you agree, everyone, with that point?
I like this definition that you use. I've used it as well. The other definitions in terms of time frames, when you start saying 3 months, 4 months, they're pointless because it depends on the fracture. I agree.
Good. Yeah, that's right. So I thought this is the, this way at least you're impressing them that you're trying to push them to what you know of what we've discussed earlier. So just repeating the same stages and types. Yeah. Okay. So moving on to the stress strain. Just now, remember we talked about strain. I think this is something you need to know, that what is strain is a change in length of the fracture gap by the gap. And we do know that direct bone will be formed with low stress and strain. So just remember that low stress, low strain, good for direct bone. And tell the examiner, I do know what strain is. It is a change in length of the fracture gap by the fracture gap. Then now let's come down to what will contribute to our healing or not contribute to our healing. So direct electromagnetic waves or currents, that the direct DC will stimulate an inflammatory-like response, which let's accept any inflammatory response is going to be good for healing. The AC, alternate current, actually is more in favor for collagen synthesis and calcification. Okay, so these are things. Remember, direct current is for inflammatory-like response, and the alternate currents will affect the collagen synthesis and the calcification. Then now, because we know what's happening at the stages of fracture healing, what is happening at the cell level, what is happening in the types of fracture healing, let's have a scenario where the examiner has told you this is a fracture with so much of comminution and it's a large degloving injury. What do you think? Is it good for fracture healing or not? And then you'll say, I think it's not good for fracture healing, and you'll give your reasons why. And then let's take each reason down to the cell level for what is truly happening at the fracture healing level. So for nerve function, you can say, if you know there's a fracture in a limb which has a nerve deficit as well, so nerve injury, is it conducive or not conducive for fracture healing? We know it's not conducive, but do we know why? And the answer for that is that there's something called a calcitonin gene-related peptide, which is in the body responsible for vasodilation. Now we know vasodilation is good, it's getting blood in. But when you have a nerve injury, that may be affected. And therefore a nerve injury indirectly is affecting vascularity because of this peptide. And therefore it is contributing to a bad result. So now doesn't it make sense that we are talking that, yes, I don't want a nerve injury because it affects the calcitonin gene-related peptide. It normally is a vasodilator, good for vascularity, but that's not happening. So the vascularity part is affected. Next, a vascular injury is well known. We know that a vascular injury will have a higher delayed union. And the reason for that is, once again, vascularity is affected to the bone. Vascularity is important for your stages. and you can say which stages is vascularly important for. Tell the examiner, I do know it's very important for your inflammation and hematoma, because your platelets are responsible for that. The second stage, what was that? Angiogenesis and cartilage formation, that is affected. So therefore, I do know that a vascular injury is detrimental. Then say a compartment syndrome, unfortunately, will have a combination of both. It'll have a vascular, it's not truly a vascular injury, but we do know there'll be a vascular compromise. And hence, once again, tell the examiner that is not good for fracture healing, because my stage 1, my inflammation hematoma is affected. My stage 2 of angiogenesis is affected. And then stage 3 will be that copious irrigation. We all do it. Every open fracture, we say there should be water on the floor, 6 liters, 8 liters. But truly, at the cell level, is it detrimental or beneficial? That if you look at it logically, irrigation is going to take your hematoma and your first response away. So at the cell level, at least, it is detrimental. Let's move on to the examiner giving you another thing. Is why do we not give anticoagulants? Are they good or are they not good for fracture healing? The answer would be that anticoagulants not good for fracture healing because they inhibit clot formation. All the signaling molecules, all the factors which were responsible for your stage 1 of healing, which is forming a clot, macrophages coming in, fibrin forming a clot, platelets calling your signal molecules, all that is inhibited by your anticoagulants. So it's not good for fracture healing. Examiner asks you is, should we give NSAIDs to patients who, while they're healing a fracture or not, and why not? Once again, NSAIDs, inhibition of prostaglandins. Which stage? Tell the examiner, I know in my first stage, the inflammation and hematoma, and my second stage will be affected. Is smoking good or not? We all know smoking is not good. Reason would be there's vasoconstrictant by nicotine. Definitely my stage 1 of hematoma and inflammation, and more importantly, the stage 2 of angiogenesis will be markedly affected, and hence I will tell my patient not to smoke. And then we have mechanical factors. Is large bone gaps are adverse. So this is more or less where I feel that most of the topics should be covered in fracture healing. And I hope I've made it in half an hour as simple as I could, or we can, rather than just reading words and then not knowing what we are saying, sometimes with difficult topics. So thanks very much. If there are any questions on this, or if my mentors want to add, because really, if any of you want to add something to this, please feel free. Thank you very much, everyone.
Thank you very much. A very concise and very logical stepwise progress through a topic which often can get confusing.